Welcome to Pediatric Podcast for PedsCases.com.
Hello, everyone. Welcome to our podcast on pediatric spirometry for Peds cases. My name is Rafiaa Valji. I recently finished my fellowship training in pediatric respirology and am now a pediatric respirologist at the University of Manitoba. This podcast was produced in collaboration with Dr. Tamizan Kherani, a pediatric respirologist at the University of Alberta. Spirometry is an easy, accessible tool to better understand pulmonary physiology. After listening to this podcast, the learner should be able to, number one, understand lung volumes, including total lung capacity, tidal volume, vital capacity, functional residual capacity, and residual volume. Number two, have an approach to the interpretation of spirometry. And number three, understand the role of spirometry in diagnosing and monitoring patients with asthma. Let's start with a clinical case. Jessica is an 8-year-old girl with a 1-year history of cough and shortness of breath. Her symptoms are triggered by playing volleyball, being exposed to cold air during the long Canadian winters, or being around dogs and cats. She feels short of breath and wakes up coughing about 2 nights per week. In terms of her past medical history, she has been healthy for the last several years, but as an infant, she would often wheeze during viral illnesses. She was even seen in the emergency department twice during these episodes, and she seemed to get better with salbutamol. She is not taking any medications. She does not have any known allergies. She is fully immunized. You suspect a diagnosis of asthma since she has some of the classic asthma symptoms, like cough, shortness of breath, wheeze, and chest tightness. The variability in her symptoms with exposure to triggers is also typical for asthma. The worsening of symptoms at night also makes you wonder about asthma. Now, how do we make a diagnosis of asthma? Based on the Canadian Thoracic Society and GINA, Global Initiative for Asthma Guidelines, there must be 2 things to make a diagnosis of asthma. Number 1, there must be a clinical history suggestive of asthma. And number 2, there must be objective evidence of variable expiratory airflow limitation. Now that's a big phrase. Let's break that down. Variable expiratory airflow limitation means that there is limitation or obstruction to airflow on exhalation, and this limitation to flow varies depending on the presence of triggers. One of the key tests used to show this variable expiratory airflow limitation is spirometry with bronchodilator reversibility testing, where we measure the impact of the short-acting bronchodilator, like salbutamol, which is also known as Ventolin or albuterol, on lung function. To better understand spirometry, we need to understand basic lung volumes. If you're listening to the audio version of this podcast, you can find diagrams explaining these concepts at www.pedscases.com. Nowadays, we use electronic spirometers, but previously water spirometers were used. As the subject did breathing maneuvers, the water level would fluctuate, and a pen would create a graph on a piece of paper. This graph shows volume on the y-axis and the passage of time on the x-axis. Here in Figure 1, you can see that with normal breathing at rest, the volume of gas that is moved with each inspiration and expiration is called the tidal volume. When we are doing this regular tidal volume breathing, the volume of gas that is present in our lungs at the end of a normal expiration is called the functional residual capacity. When we take a big breath in, which is also called a maximal inspiration, we get to our total lung capacity. When we maximally exhale after that, the amount of air left in the lung is called the residual volume. So what's interesting about the lungs is that we can never fully deflate them. There is always some volume of gas present in them, no matter how hard we try. When we go from inflating our lung all the way to total lung capacity, and then exhaling as much as we can all the way down to residual volume, that difference in volume is called the vital capacity. Now we will talk about the breathing maneuvers that happen during spirometry. Here in Figure 2, we have a flow volume loop. We have flow on the y-axis and volumes on the x-axis. Flow is measured in liters per second, and you can think of it as the speed of gas being inhaled or exhaled. Positive flows are associated with expiration, and these are on the positive y-axis. Negative flows are associated with inspiration, and these are on the negative y-axis. The volume, as measured in liters on the x-axis, refers to the volume inhaled or exhaled. With spirometry, the key maneuver is the forced vital capacity maneuver. There are 4 steps in this maneuver. The patient starts off with regular tidal breathing, just like we're all doing at rest right now. Now remember that with regular tidal breathing, the volume of air in our lungs corresponds to our functional residual capacity. The subject then takes a rapid, big breath to achieve a maximal inspiration, so now their lung is at their total lung capacity. When looking at the flow volume loop, the generation of negative flow corresponds to the negative portion of the y-axis, so you should ideally see an even half circle. This is the inspiratory limb. Then the patient blasts the air out as hard and fast as they can for as long as they can, even if it feels like there is no air coming out of their lungs. This exhalation phase is seen on the positive y-axis. At the end of this phase, the amount of air in the lung corresponds to the residual volume. Then the subject takes a big inspiration back to the total lung capacity. Now, as you can probably tell, there is a lot of coordination involved with doing this test properly. Generally, children younger than 6 years of age will not be able to do spirometry reliably. There are also specific technical criteria which define what is considered an interpretable test. To interpret the flow volume loop, there are a few important parameters to know about. You can follow along on Figure 3. Now, there's the peak expiratory flow rate. This is the highest flow rate during the forced vital capacity maneuver, and it's literally the peak that you see on the expiratory flow curve. There's the FEV1, which is the forced expiratory volume in the first second of the FVC maneuver. And this is exactly what it sounds like. It's literally the first second of the forced vital capacity maneuver. This volume is easily identified on the volume time curve. Then we have the FVC, or the forced vital capacity, which is the total volume exhaled as forcefully and completely as possible when starting from full inspiration. The FEV1 over FVC ratio is the ratio of the FEV1, so how much air was blown out in the first second in liters, divided by the FVC, which is the total volume of air in liters that was forcefully exhaled. Now we can go through the interpretation of a spirometry report. Take a look at Figure 4. So just like every other test, it is important to make sure that it's the right patient. So take a look at the demographic details, including the name, age, height, and biological gender. I also look at the BMI, the body mass index, since obesity affects lung function parameters. Patients with obesity sometimes have a lower functional residual capacity, which is actually measured on lung volume testing, a different type of pulmonary function test. I also look at the smoking and vaping status, if commented on. Of note, patients are told not to smoke, vape, or use a pipe in the 1 hour before testing. Then take a look at the technician's comments to get a sense of how well the test was performed. young children are more likely to struggle with performing the test properly. A poor quality test may be reliable for some measurements, or it may be misleading and not worth interpreting at all. Of note, there are more detailed descriptions of the technical parameters for a good quality test, which can be found in the American Thoracic Society statements, but we won't discuss those further today. When looking at the report as a whole, there are three main sections. There's the flow volume loop. Now, although the patient would have had to have at least 3 good quality flow volume loops to be completed, as part of the technical criteria requirements, you only see one representative flow volume loop on the printout. You will also see a volume time curve, which shows the exhaled volume as a function of time. Time 0 corresponds to the start of the exhalation. As exhalation continues and the lungs continue to empty, the total exhaled volume starts to plateau, and this tells you that the patient truly put in maximal effort. You will also see the actual numbers for the parameters we have talked about, including the FEV1, the FVC, and the FEV1 over FVC ratio. There's also some other numbers listed, but you won't need to focus on those when you are first learning spirometry interpretation. In one column, you will see the values measured for that patient. In the next column, you will see the reference values. Ideally, there should be 2 reference values, an upper limit and lower limit of normal, as based on the Global Lung Function Initiative reference values. These reference values are based on age, height, gender, and ethnicity. Let's move on with the interpretation. You can then look at the flow volume loop to get a sense if it looks normal or not. The 2 big categories of lung diseases from a physiologic perspective are obstructive and restrictive. Obstructive diseases involve obstruction or narrowing of small airways, and some examples include asthma, cystic fibrosis, and COPD. As you can see in Figure 5, the expiratory limb has a scooped appearance. In restrictive lung diseases, the lung is basically restricted from expanding to the size it naturally wants to, and so it is smaller. Some examples include intrathoracic causes of restriction, like interstitial lung diseases, or extrathoracic causes of restriction, like severe scoliosis. As you can see, the flow volume loop has a more narrow or contracted appearance. Now that we have a sense of what we're expecting based on the visual appearance of the flow volume loop, let's take a look at the actual numbers. First, look at the FEV1 over FVC ratio, which is the ratio of how much air was blown out in the first second, divided by the total volume of air that was forcefully exhaled in the forced vital capacity maneuver. If this ratio is less than what is expected, so less than the lower limit of normal, then there is evidence of airflow obstruction. In this case, the FEV1 over FVC ratio is greater than the lower limit of normal, so there is no evidence of obstruction. And the spirometry loop also looks normal with no scooping. For many diseases, including asthma and cystic fibrosis, the FEV1 is regarded as a summary measure of lung function and is tracked over time. Now, if there was evidence of airflow obstruction, then we could stage the severity of the obstruction based on the FEV1. Mild airflow obstruction is where the FEV1 is more than 70% predicted. Moderate is where the FEV1 is 60 to 69% predicted. Moderately severe is an FEV1 of 50 to 59% predicted. Severe would be 35 to 49%, and very severe would be an FEV1 of less than 35%. Next, take a look at the FVC. Again, look at the range of normal values and see if the FVC is greater than the lower limit of normal. If there is no range given, then a FVC of 80 to 120% of predicted is generally considered normal. There are 2 reasons for why the FVC could be decreased. Number 1, if there is a restrictive lung disease, and the lung is actually smaller and so less inflated, and so therefore there is less air to be emptied. And 2, if there is significant airflow obstruction, so essentially there is so much obstruction that the lung cannot be emptied to the extent that it normally would. The only way to definitively sort this out would be to obtain lung volume measurements, which is outside the scope of our podcast today. However, in this case, the FVC is greater than the lower limit of normal, so the FVC is normal. The other values that show up on the spirometry report are going to be less important when you are first learning spirometry. The FVF 25 to 75% has traditionally been thought of as reflecting flow in the smaller airways, but there are some concerns more recently that this number is not as reliable in children. So now we should take a look at how the use of a bronchodilator affected the patient's expiratory airflow. The way this is done is that after the patient did the initial testing, they are given 4 puffs of Ventolin, 100 mcg per puff. After 10 to 15 minutes, the flow volume loop is repeated. In the context of asthma, you are looking for a significant bronchodilator response, which is defined as having a greater than or equal to 12% increase in the FEV1 after the bronchodilator is given. In children 12 years of age and older, as well as adults, you're looking for the 12% increase plus a 200 ml increase in the absolute value of the FEV1. In this case, there was no significant change in the FEV1 with use of a bronchodilator. So overall, this spirometry is normal. Now, getting back to our case, so when you look at our patient's spirometry, visually her flow volume loop has a scooped appearance and looks better after the salbutamol was given. The inspiratory limb looks nice and round, so you're not worried about an upper airway pathology. When you look at the numbers, you find that her FEV1 over FVC ratio of 79 is below the lower limit of normal for her age, which would be 86. This means that there is evidence of expiratory airflow obstruction. The FEV1 is 76% of predicted, which corresponds to mild airflow obstruction. Then you look at the FVC, which is within the normal range for age, as compared to the lower limit of normal. Next, you look at how Ventolin affects the FEV1. The FEV1 improves by 28% after she receives salbutamol. So overall, the spirometry shows mild airflow obstruction with a positive bronchodilator response. Putting everything together, Jessica's clinical history and spirometry confirm a diagnosis of asthma. You start her on a daily inhaled corticosteroid with salbutamol as needed and plan to see her back in follow-up in 3 months. At the follow-up visit, she says that her symptoms are significantly improved. She can now play volleyball without stopping to catch her breath. She is sleeping better at night and not waking up, short of breath. You repeat the spirometry and find that her FEV1 over FVC ratio is now normal. Her FEV1 has significantly improved. Overall, there is clinical and spirometry improvement with asthma treatment. Great job, everyone. So the take-home points to remember today are: Number 1, spirometry is a helpful tool in children 6 years of age and older to better understand pulmonary physiology. Number 2, as our case illustrates, spirometry combined with symptoms is an important part of making a diagnosis of asthma. Number 3, the key maneuver in spirometry is the forced vital capacity maneuver. That's the one where the patient takes a big breath in all the way to total lung capacity and then blows out as hard and fast as they can. And number 4, when looking at spirometry, take a look first at the demographics, then the technical comments, then the FEV1 over FVC ratio, then the FVC, and then see if there's a significant bronchodilator response or not. That's everything today, everyone. Thanks so much for tuning in. Take care.
Check out www.pedscases.com for more great podcasts, videos, interactive cases, questions, and more. Press subscribe on iTunes to get access to all of our podcasts. If you like what we do, please leave a review on the iTunes Store, share with your friends and colleagues, or think about getting involved.